Today this is Dr. Samira Khan, and I'm going to discuss about the course that I am offering as a MRCOG MRCPI tutor. And this is going to be, I'm conducting part 2 courses for MRCOG, part 2 OSCE for MRCPI, and part 3 MRCOG. I have been doing part 3 MRCOG courses, but I realized that before I'll tell you what I realized about this exam, my experience, I want to share with you my experience. I went to UK after I passed my part 2 in London, and I stayed there for 3 weeks, attended like three courses over there. I didn't pass, I failed, okay? Second time I went to Abu Dhabi and I passed the exam. It's not that because anything to do with the place, but I realized that I didn't pass from the first attempt. Many other reasons, but the most important reason was I didn't revise my knowledge well, and basically I was having some difficulty in structured viva, which is usually focused on knowledge, and even for the simulated patient part, I was having difficulty in knowledge. Because why I'm stressing on this point, because people used to tell me, now you pass your part 2, your knowledge is perfect, you don't need, I mean, you need to revise it like quickly, just the bold letters, and concentrate on your skills for communication skills especially. So this is how I was being told, but I found it completely opposite. Actually, I failed in my exam because I was not very good in knowledge, and then I didn't revise well. So knowledge is as important. If someone will tell you that knowledge is, you have passed your part 2 and you are perfect and you don't need to revise it, or you don't need to think about it or take care for it, that is not true. So that's why I want to concentrate not only on the skills, but also on knowledge part. And there is a difference between knowledge of part 2 and knowledge for part 3. How you grasp, how you are supposed to read for part 2 knowledge, and how you are supposed to read for part 3 knowledge. There is a difference. And this is exactly, I want to show you by giving you an example in through this presentation, that what is the difference. But you need to read your theory. Of course, it is different from how you will read for part 2, but still you need to read your theory in a different way. You cannot neglect it at all. Okay, so let's come a brief introduction of my course, and then we will go and do our we will discuss how we are going to do the stations and what should be done, and how you should present, how you should prepare your bullet points, and all these things. Okay, so it's for part 3, and it's a 3 months course, because there is no fixed date announced for the overseas candidates for part 3. That's why I cannot announce a specific, like just before the exam or something. So I just announce randomly, and we will start from January. I will focus on especially on the theoretical part of the scenarios. I want you to understand how to do the station, and we will do the stations together with it also. So, but I will not only concentrate on practicing stations with you, which all of us are doing, which I have been doing before, but I will concentrate on how to approach the station, so that any station will come, you will be able to answer, you will be able to do it, whatever the kind of situation, if you have not read this scenario before, you should be able to pass this station. And it is possible that you never read that uh, about knowledge about it, you don't have knowledge, but still you are able to pass that station. So it's just a matter of a few tricks and you will learn it. There's no problem at all. And you can pass from second attempt. No one told me about these tricks, although I attended my 3 courses in London and in Birmingham and all these places in UK, I mean, but I it didn't help me actually. Okay. So it will be something like this. We will go module wise. We'll do teaching and surgical. We'll do antenatal maternal medicine, intrapartum, then postpartum, general gynae, subfertility, and I will divide it into 2: subfertility and sexual and reproductive health, and then urogynae, early pregnancy, gynae, oncology. We will divide the modules. It will be like almost 3 to 4 hour session, and because I'm concentrating also on theory part, that's why I will provide you with the material, the right material that you need to read for that particular station, and not only for that particular station. If I am doing a module for urogynae, for example, I'll provide you with all the right material that is needed to do all kind of stations of for urogynae. So I'm not concentrating on one. I want you to pass the exam, so that's why I have to provide the right material for part 3 related to all the module. This is what is the different thing what I'm doing, what I'm planning to do this time. Before, I was providing the material, usually the guideline and the talk article related to the scenario, but now I want to cover all module. Okay, and we will discuss about all the recalls which came in the last 5 years, because they are repeating. They are repeating themselves. They don't have too many topics. Their question bank is not very. They are concentrating on some special topics which is important for OSCE, and then because how I know that these topics are important for RCOG for part 3, because I have been doing recalls. So that's how I know that these, okay, they are repeating them, these kind of topics again and again. So maybe this is important for them. Okay. And then you are in contact with me through Telegram and through WhatsApp 24/7. And before you come to my course, it is better to read at least 1 or 2 OSCE books, and you should have a study partner. There is no there is one book of Justin Conje nowadays, which I like it most. For me, previously I read these books, but nowadays everything, because is updated, guidelines are being updated very, very frequently nowadays. And so we need to keep our knowledge updated. And I'll take mock exam at the end. I want to say something. There is a quotation which I want to, which especially I bring it here because I like it. I really like this one. Some people will say, I like the car more than the quotation, especially the boys, but just look at it. When you want to succeed as bad as you want to breathe, then you will be successful, isn't it? So let's move to my presentation for the urogynae scenarios. Okay. And let me open it. Yeah, here you go. So can you see my screen? I want to see Dr. Bushra, you are there? Can you open your mic?
Yes, Dr. Samira. Assalamu alaikum.
Walaikum assalam. Because you are my student from my course, I want you to keep your mic open. Dr. Swati is here, Suzanne is here, and some others will join also. Anyway, you are at the top of the list, so I'll start with you. So you keep your mic open, Bushra.
Okay.
Okay, so because I'm going to ask you questions. Dr. Doha is not here, and Sabiha is not here also. So unfortunately, I'll ask you. So Dr. Bushra, I want to ask you that, okay, we have been practicing stations, and I have been posting the information about it. So what do you think in like 3 lines that is important for the theory part or the knowledge part for part 3? What are the 3 important things that you need to read?
We need to read according to this, as we should know the differential diagnosis of any complaint. If a patient is having a complaint, so what can be the differential diagnosis?
This is your skill. This is your skill of approaching a station, right? This is your clinical skill, and it will only come with practice. We will do practice, and we have been doing the practice, and this is how you will learn the skill. And you have to study, you have to share what you call it, practice with your study partner. This is how you will learn the skill. But from the theory part, what you need to study from the theory part, this is what I want to know.
You mean guidelines and talk articles like that?
Okay, how to read
Or
the
of a topic?
guidelines?
Yeah.
Guidelines, talk articles. Yes, you have a strategy. This is part
Yeah.
2, isn't it?
Yes, for according to MRCG part 3, what I understand that we have to emphasize more on the management part. That if a patient has this diagnosis, so how we have to take her further. But definitely to reach that till that diagnosis, it is also important, that which you have already said, that it will come by our practice, by skills, that you should know differential, you should know risk factors, then we will come diagnosis. But after that, the management options actually which we have to give to the patient to return in back her wishes.
That's
This
true.
is what I understand, it is important.
Yeah,
That we
there is
should
no
know we
way.
have.
There is no way you pass this exam if you are not concentrating on management.
If we are confirm on management, we
Yes.
will cover applied knowledge, we will cover
Yes.
safety, we will cover communication with colleagues.
Yes, that's
And
true.
what is
You can
this
even if you, for example, symptoms, what is given
yeah.
in the talk articles and guidelines, you can create questions from the simulated patient, for example,
Yeah.
if you know the management. But the management is the crucial part to read from any talk article and any strategy or guideline about a topic. Okay, so you need to concentrate on management. And in management, by the way, in part 3, management starts from history. You know that, right?
Yeah.
Anyway, you have to read management, and management starts with history. Okay.
Yeah, what
So
I understood, when we see a scenario, we make some differentials in our mind and management of those differentials. So through this history information gathering, we take this whole history information gathering to make a management.
yeah, I want to rephrase it, what you are saying. It is very important
Yeah.
point, because you have to think broadly. In a guideline, you are concentrating on one topic. In a talk article, you are concentrating on one topic. But when you are in part 3 scenario, you are sitting in a clinic. Assume yourself that patient is in front of you. This is how I was doing my exam. I assume that I'm sitting in a clinic and there is a real patient in front of me. So how you are thinking broadly. what does it mean? By doing the differential diagnosis. This is how you will think broadly. It's not that one topic and one guideline you are applying. In one scenario, they combine usually 2 or 3 things. So, Dr. Bushra, if there is a scenario of chronic renal failure, they might combine a patient who is 18 years old. So there is a teenage pregnancy, and if you will not talk about, for example, in a postpartum scenario, they expect you to talk about the normal postpartum uh, normal postpartum complaints, like ask her about her lochia, ask her about the breastfeeding, how is the baby doing, and it carries marks. It looks so, and contraception, yes. So it looks so simple, and I know you will only concentrate on the postpartum fistula or whatever she has, or incontinence, and you can easily forget about the
main things, general things.
I mean the general things which carries marks also. So always in one scenario, like in one patient, in real world also, in real practice, patient will not come with one complaint and only you fit on one guideline on her. She will have like 2 3 at least multiple problems, and you are taking her as an individualized scenario, which is a combination of like 2 3 4 things, and you combine them all together. Then you do your differential diagnosis. You reach your diagnosis by taking history, examination, investigation, and then you manage her. This is how you are doing practically. This is exactly how assume yourself sitting in a clinic. Now, if you don't have the right knowledge, my point is, if you don't have the right knowledge, by right knowledge, I mean not the knowledge that we used to hear from our seniors while we are sitting in a clinic, the knowledge that they want, because we are going for RCOG, UK exam, right? So they want knowledge from their RCOG site. What is prevalent in their country? This is what they want, right? And so you need to read their from the RCOG site. So knowledge is important. Again, if your knowledge is deficient, then even if your skills are very good in communication, my skills first time, I didn't pass the exam first time. I had excellent communication skills. Okay, but knowledge
is must. Knowledge is must.
Yeah. So because I have gone through, and when I was preparing for my part 3, everyone told me, you pass your part 2. Now your knowledge is perfect. You don't need to, concentrate on your knowledge. You can revise a little bit, but no need to concentrate on it. Even in the courses of UK courses, this is exactly what every course said. You just need to practice with your study partner your communication skills and skills, and generally speaking.
This sentence is the biggest, what I will say, this sentence is the biggest thing which make us lose exam in first attempt.
This is good for a British candidate. Why?
Yeah, maybe because they are practicing there.
They are practicing the same thing, what is written, and their seniors are telling them exactly the same thing. Their consultants, what they have read,
they're asking in the exam.
Yeah, what they're asking in the exam also, and they know what they will ask in the exam. This is not for us, baby. This is not for us. So you have to have good knowledge, and of course you know that you have to read the patient information leaflets, and there is a section of patient on top right in the RCOG website, where it is written after guideline. It is written examination courses and examination guidelines, and then on the right extreme upper corner it's written patients. So you need to click on it, and there all the patient information related to the gynae, related to the obs, related to the surgical procedure, recovering well guidelines, You need to read all of them, because your simulated patient, how you are going to counsel the patient, what the percentage and how you are going to explain a condition, the percentages exactly that you are going to tell her is written over there. So you need to read your patient information leaflets if you want to do. Oh, there are many people waiting, sorry. I become just lost. Okay. So you have 2 minutes outside. So I cannot stress more than this on the knowledge part. I mean, because I suffered, that's why I spend like 10 minutes just talking about the knowledge part. I don't want you to lose from the first attempt. There is more than 70% pass chance that you might pass in the first attempt. And I don't want you to lose it just because someone will tell you that the knowledge part is not that important. No, that's not true.
It's a myth. It's a myth.
Yeah. And it's not, maybe it is,
important.
maybe it's good. This statement is good enough for a British candidate, but not for an overseas candidate. Okay, so now coming to the stations, you should have a study partner. So Dr. Bushra, do you have a study partner? Don't tell me no.
Often, doctor, nowadays I'm losing my study partners because there's no time for exam. So we don't have any aim.
No motivation. And this is another reason why I want to bring a course. We have to keep our motivation. Whatever is going on in the world related to pandemic, it should not affect us. Believe me or not, that for me, when I was going for exam, not the pandemic, but many things happened, you know. My mother passed away and I was having exam, and because we were giving exam for long, I don't pass part 2 in first attempt, of course. So our process of passing this exam is for overseas a little bit long, you know that. So
yes, and at
yes.
when you pass, it was not part 3, right? It was part 2 only. Right?
What do you mean?
Means theory and OSCE together, not separate attempts. Right?
No. I passed in 2015, my part 3.
Part 3 has came at that time. Okay.
Of course, I'm not that old. Come on.
It's not necessary.
I'm an antique or what? Not an
So
antique.
many people very young has done so many things, Dr. Samira.
No, it is there. Part 3 is
More
there
than
since
old
long
ones.
time. More than, I don't know, more than 10
Five,
years or 15 years.
five.
Part 3 is still there. It's an OSCE. It's an OSCE since long time.
No,
Okay.
part 2 and means theory and part 3 separate since 2016, Dr. Samira. 17 maybe, not from 2015. Means theory passed and then there are 4 attempts of part 3.
Yeah.
Before they were together.
Yeah, but you have to give them together. You know what happened to me? I immediately after me, it became
Yeah, maybe 2016 or 17 part
yeah,
3
because
started. Not in 15.
I gave in the September one in 2015, and immediately from the next one,
Immediately,
it
you
became
have to give exam.
like a
OSCE.
choice that you can
Yeah.
go after 6 months or 1 year.
Okay.
It was your choice. But I think that this is not very good. You know why? It's good and it's bad, because you are postponing, and sometimes
Yes.
it never happened before that you will not get a chance. Once you pass theory, then all of them will have chance. All of them will have chance to go to next OSCE. But it was not very good for me, because I have to apply for visa, and it was refused, and I have so I all the time I was in stress of a application of visa application. It took all my time. There was no time for revision.
Yeah. It's also a big deal to arrange for visa.
Yes. So for overseas, I mean, we have different kind of challenges. But we need to keep our motivation. So it might be a good thing for us for overseas, that we can delay after 6 months or a year, but we need to keep our motivation. This is a challenge also. to keep ourselves. Now, what I was saying before about, for
Knowledge
example,
part.
yeah, knowledge part is finished. Now let's come to the once you are there, you are in UK, or you are in one of the centers, overseas centers, and you manage to be there. Okay, and I'm not talking about how you manage to be there. This is another session maybe. But once you are there, and you are standing outside, and the scenario is in front of you at the outer wall, right, pasted, or sometimes it's down. Some of the candidates told me that sometimes the scenario, it's not on the wall, it's not pasted on the wall, which didn't happen with me, but they are saying that it might be on the floor down. So you have to look at the floor if it, yeah, so you have to look where is it. So literally speaking, they are saying that you have I mean 2 minutes to read the scenario outside, isn't it? After the bell rings, then you go to the next station, you have 2 minutes. But literally speaking, it is less than 2 minutes.
Less than, yes.
Yeah, because you need some time to adjust, to move from one to another place, and then adjust your eyes, I mean, fix and try to bring all your attention towards it. I think it will take few seconds. For me, it, it it's taking few seconds. And when I was giving exam, it was 1 minute, and half of the time was for me was lost in trying to bring myself together, so it was very difficult, 1 minute, but 2 minutes is good. It's more than enough. It should be more than enough. Even we practiced before to read and to understand and write bullet points on our on our diary, which is given by them at the beginning, within this 1 minute, which was a challenge. And we have been practicing this to do it within a minute with the study partner. It was something, and it was difficult. But 2 minutes is more than enough. You can do it very well in 2 minutes, within 2 minutes, I mean. So the question is what to write in bullet points. For example, I'm giving you an example, and I want to ask you what you should write in this 2 minutes. Just say write in 1 minute instead of 2 minutes, because you might have like 1 minute actually. For example, this is the scenario. It's a recall, and I want you to just take 1 minute, all of you please, because if Dr. Bushra miss anything, I can ask anyone what else that needs to be written in the bullet points. Now your 1 minute starts now. I want all of you to write bullet points. Okay, Bushra.
Hello, I'm
Yeah.
Dr. Bushra, one of the doctor in duty.
No, I don't
today.
want you to do the station.
Then,
What you?
sorry, I thought the same.
Because we are doing this since long time, the same thing again and again, so it's stuck to your mind. So I want you to write the bullet points. Did you
Okay.
write the bullet points?
I didn't write, but I
Okay,
did my
because
part.
you spent 1 minute, just tell me
Yeah,
what is in your mind, what you should write, because you will be given a notebook, right?
yes.
So what you will write in bullet points?
In this patient, the age is important, which
Yeah.
I understood from this
No,
scenario.
just tell me
Age
the
is
bullet points. 1, 2, 3, 4, 5.
okay. Her first in my mind, I selected that yes, I will introduce
The
myself
bullet
and make
points is
agenda. That's like that.
no. Stop.
But I have to make this, Dr. Samira, because I have to start with this. It will be my first impression, and
Okay.
then when I will start
Just
my
finish and
other
then I
things.
will tell you.
Yeah, I'm not writing it in this 2 minutes because no time. But in my mind, I have to revise that how I'm going to start when I will enter myself.
Mm-hmm.
Then yes, what is the case that something coming down means it will be some prolapse.
Mm-hmm.
So for this age of the
Yeah,
patient, I
now
have to
you are
take
coming
the
to the point.
yeah.
First bullet point
Uh,
is prolapse. This is prolapse,
yeah.
and you need to discuss about prolapse. Okay.
Yeah,
Then,
in history, I would like to ask about the risk factors of this patient, how this prolapse will come. Like in my history, I must like ask about any symptoms which she's having about this something coming out since how long, at stress or all the time. Is she able to
so in this
really?
1 minute, you are not going to explain
Yeah.
what you will do. Just tell me that I'll ask the history. Okay.
Yeah.
And in history, this is this is something that should be in the back of your mind, that I will take the
Yeah.
history, right? There is nothing to write. What are the things
Yeah.
that you should write?
I should write it for what I will do. I will write the management option along
Yeah,
with her
okay.
history points.
Management
If any
options.
issues, maybe
What
this
is in
patient have
management
issues.
options you will write?
In this prolapse patient, pessary, conservative or surgical. Conservative is
So
pessaries
these are
which
your
she can
bullet
use
points.
and
You are writing
options. Yeah,
pessary
surgery and surgical options.
and you are writing surgical options, and you make an arrow. What are the surgical options
Yeah.
that you want to discuss with
Surgical
her?
option will yeah, surgical options again depend on the condition of the patient, prolapse, degree of prolapse, patient history,
This,
whether she
this,
is fit
this
for
is, you will
surgery or
discuss it
not.
inside. No need to
Yeah,
go in detail.
yes.
Just tell me 3
Yeah.
points of surgical.
Uh, 3 points will be anterior and posterior repair and hysterectomy
So
and
you mean vaginal
colpocasis.
hysterectomy and pelvic
Yeah,
floor repair. Okay,
repair
this is your
or
first.
colpocasis. Yeah,
Now the
bend.
second surgical point. You are writing bullet points only. You are not explaining
Yeah.
here. Okay, second.
Uh,
This is
Second
what
in
you need to
surgery.
practice. You should.
Yeah, in second,
All these
what would be
bullet
the
points
risk
should
and
come to
pros?
your mind within 1 minute. So what's the second option?
Second option is this vaginal repair and hysterectomy and colpocalysis. Plus, there are pros and cons. What are the risks and benefits of the surgery, and which is suitable for this patient, not suitable for the
You
patient?
mean colpocalysis? And what's the
Yeah,
third thing you said?
with anterior posterior repair. Maybe
Yeah,
we
you
don't know
you
which
already
kind of
said
prolapse
vaginal
surgery there.
hysterectomy and pelvic floor repair
Repair.
is 1 point. Second point, colpocalysis. What's the third option? She has any third option?
Uh, yes, that is something.
Especially if she want to keep her uterus.
Yes, um,
Not every woman.
hysterectomy, right?
Yes.
Um,
And what are the approaches that you might take?
abdominal and
Okay.
abdominal sacrocolpopexy
Mhm.
and sacrospinous fixation,
Can it be
right?
laparoscopically done?
Yeah, it can be done
Okay, so
laparoscopically,
abdominal
abdominally,
and
or can be vaginally, both. It can be done.
You can say sacrohysteropaxy instead of sacrocolpopaxy, because I think this is for vault prolapse. In the vault prolapse guideline, they talk about
Yes.
sacrocolpopaxy. So anyway, so these are the bullet points that you want to talk about. This is in your mind, right? First of all, you said this is prolapse. Okay, you write this as prolapse. Then you write management options 3. PAS3, I want to talk about pelvic floor muscle exercise. I want to talk about surgical, 3 options, vaginal hysterectomy, plus pelvic floor repair, colpoclasis. I want to talk about sacrohysteropaxy, which might be abdominal laparoscopic. This is what I will talk about. Anything else? Important regarding the safety point, because you cannot pass a station if you will leave any safety point. Patient safety. You will be tested for patient safety, right? And if you are a little bit, why they are not stressing too much in other, but because you cannot pass the station if you are not concentrating on this patient safety. What you might think that is the safety point?
In a
General,
safety,
I told you, general
yes, general
and
and
specific.
specific. General in this patient is regarding informed to the consultant allergy or
Yeah.
any red flag symptoms of this patient of prolapse. Maybe it is related with some vaginal bleeding, vaginal infection.
So you will ask about postmenopausal bleeding. You will make
Yeah.
sure that she's not having an ovarian tumor or a pelvic, actually
Or
pelvic
pelvic,
mass, which might be a cancer, which might be cancerous
in
at
this age
this age.
especially.
So which is putting pressure on her uterus. That's why it is prolapsed. And you will take your consultant in loop, multidisciplinary team approach, and allergy. You will ask about it. So these are the general and specific safety points. And
In this,
in management also, you have to, if you are going for surgery, then you need to
her
make sure that
medical
if
and
she's,
surgical history is also important.
yes, her previous surgical history is important, medical
And
history is
medical
important.
history.
Yes,
Yeah, the
because
diabetes, because
78
in this
years,
age can be.
yeah, can be like comorbidities. And so multidisciplinary team might be approached. Instead of general anesthesia, you might need to do it under, unless it's a laparoscopy, then you might need to do it under spinal, regional anesthesia. So anesthesia consultation. There are specific issues related to this age also. Okay, which is included in the safety point. Anything else want to add? Anything in the bullet point?
Also, safety will be the before reaching to the options. We have to, for decision of the options, we have to take care that if we are going for surgery, we should rule out before other problems along with this prolapse.
Of
Like if
course.
she's having infection, or this will also come into safety.
Yeah,
If
because
patient has any urinary incontinence
that's
along
true.
with this stress or urgent continence, we have to rule out and confirm that by urodynamics, involve the multidisciplinary
And maybe if
team
she has
if it
urinary
is.
retention, that maybe she is suffering from UTI, because if you will take the patient, because chronic UTI sometimes have no symptoms. So you need to check her that if she is able to void or not, any voiding dysfunction or not. And if she's
Yes.
having together with it any stress incontinence or not. And you might need to do the urodynamics before you go for the surgery. Okay, so Dr. Dr. Suzanne, can you open your mic? And Dr. Lasita.
Good evening, doctor.
Good evening. How are you?
Fine.
Good that you joined.
I was a bit late. I just finished my work. That's why.
No problem
It's
at all.
day here.
Everything is. I am recording. You will receive it. So just tell me,
Okay,
have
thank you
you
so much.
listened? Have you listened to the bullet points which Dr. Bushra said just now?
A bit, no, not fully.
So can you please tell me, okay, the scenario is in front of you. What bullet points in your mind that you will write outside?
About which one? Information gathering or patient safety, which point?
Now, okay, now I want to ask you that how you are going to approach this station. What are the important points that you need to cover inside? This is what you are going to write outside.
Okay, okay.
Just in points.
Yeah. At first instant, we feel it's a prolapse. So
Yes.
we just wanted to know about any other symptom, whether she has got any
Yes.
associated urinary symptom,
Yes.
whether she has got any bleeding per vaginum, whether it can
Yes.
be associated with a malignancy or a decubitus ulcer she can have,
Yes.
and what all daily problems she is facing. What is her important
You mean
problems?
quality of life
We have to
issues?
correct that. Yeah, quality of life, and we have to correct that during surgery.
You mean associated problems?
Yeah, associated. What all problems she have, whether main problem is urinary problems or the mass itself
You
causing
mean if
problem.
she is having stress
Any rectal
incontinence,
symptom.
then you might
Yeah,
need
any
to do a
incontinence correction also with that.
incontinence correction surgery. And what is the best incontinence correction surgery nowadays which they are recommending for stress incontinence?
The procedure, I think it's banned there.
You mean the
UK?
TVT?
Yeah, it's banned there. It's birch colpo suspension doing there.
Yeah. So TVT is
It's
not
for
banned.
prolapse.
All mesh surgeries are prolapsed, banned in UK. I heard so.
Yes.
Here we are doing TVT.
Yeah. The thing is that there are concerns. And it is given there in the RCOG site, all the concerns related to the mesh surgery. And we have to, while we are taking consent from the patient, we have to tell the patient all of these concerns. Even if she want to do it after hearing all these concerns, then they can still, it's not that completely banned, but we have to inform the patient. Informed consent is important, but usually they are turning towards Birch colpo suspension.
Birch colpo suspension. Okay, doctor.
And you can do it together with any surgery what you are doing. Okay.
Yeah.
So that's all that you will write in your bullet points regarding.
Again, we have to whether she has got any abdominal distension, ascites, or mass abdomen.
Yeah. You are ruling out any associated symptoms and malignancy.
Any allergic, any allergic
What you will
history.
write in the bullet points, that I'll rule out associated symptoms like stress incontinence, for example, and any signs of malignancy. That's it. Then come to the management options. What are the management options you will write?
It's vaginal hysterectomy with the anterior colporrhaphy and posterior colpoperineorrhaphy.
Okay.
Is it like, hello?
Yes, I'm listening.
Here we are doing like that.
Now, I want to be clear about something. Can you hear me?
Yeah.
Okay.
Yeah, I can hear. Sound is a bit less. That's all. It's not clear.
Bushra, how is my sound now?
It's okay.
Now it's okay?
It's okay always.
Because
it's always okay.
Yeah, maybe there is some problem. No problem at all. In every people network, sometimes in my network also. This is the a good thing and bad thing. Everything has pros and cons for remote teaching. Okay. So yeah, that's true. But the one thing which I want to say, Dr. Lasita, that we should refer to the RCOG. Even what I'm doing for my patient, I mean, it might be different from what is written
Yeah.
in their guidelines. So for the purpose of the exam, we should stick to the guidelines and talk articles and the RCOG material that we have on their site. Okay, so what else do you think the bullet point should be? After this, I will, can I start, can you do this station? Are you comfortable to do this station?
Because I am not familiar with part 3 actually.
Okay, so I will ask someone else to do it.
So I have, yeah, that will be better and I will catch up
Okay, no
later.
problem at all.
Okay.
So we have Dr. Suzanne. Can you open your mic? And who else? Dr. Bhavna, can you open your mic, please? Do you want to do this station?
I just joined, ma'am. I am very new to this pathway. I just joined now.
Yeah. So anyone who is, I know Sabia is there, and if I will, she's keeping herself muted because if she will start to talk, then it's difficult to stop her. And our Bushra is here also. Ultimately, I will ask either one of them. So, anyone else?
Yeah, can I try, ma'am?
Yeah, yes, but what's your name?
Yeah, I'm Surbhi.
Again?
Surbhi.
Yeah, because the name is not is different, coming different here. Okay, so Sulfi, is that how I pronounce? I'm pronouncing it well or not? I don't know. So you can do this station. Let me start your. Do you need 1 minute or
Yeah,
you?
Surbhi. Yeah.
Okay, you have written your bullet points.
Yeah, just 1 minute, ma'am. Yeah.
So we can start.
Yeah, yes.
And let me, because you have 10 minutes.
Yeah.
Okay, start now. Enter, introduce, start.
Hello, I'm Dr. Surbhi, one of the doctors in the clinic today. May I confirm your name and age, please?
Yes, doctor, welcome. I am Mrs. Rose and I'm 78 years old.
Okay, nice to meet you. How would you like me to call you?
Mrs. Rose is fine.
Okay, Mrs. Rose. As I understand that you are here today as you have some complaints of you're feeling some lump coming down. Is that correct?
Yeah, that's exactly, doctor.
Okay, Mrs. Rose, can you please tell me more about your condition?
Yeah, doctor, it start to happen like since, you can say since long time actually, more than 5 years back. I'm having this problem, but it just became worse recently. And so I really want to do something about it now because it's bothering me a lot.
So, will it be fine if I ask few more questions from you, and then I may need to examine you, and then we can come to the management plan together?
Yes, it's fine.
Okay. So, Mrs. Rose, as you mentioned that since 5 years you have noticed this thing. So, how your symptoms have changed since 5 years?
Yeah. So, doctor, I'm feeling nowadays that every now and then I'm having like some urine infection, and then I go to my GP, he will do some test, and then he will I need to take like frequent antibiotics. Also, I'm feeling pressure down much more, and I can, while I'm sitting, I squatting, I can feel something coming out, you know? So it is like
And
disturbing me a lot. Um, and
okay,
even
and
my
does that
husband has, I mean, I'm still having relationships, so my sexual relationship is also being disturbed because of this.
Oh, I'm really sorry to hear that you have to go through a lot, Mrs. Rose. So, is it affecting in any way your urination also?
Yes, sometimes I have to reduce my lump by myself, and then I'm able to pass urine. So it's, yes, it's affecting.
Okay. And what about any bowel problems you are facing?
Not exactly. Sometimes I'm having constipation, but it's not usual.
Okay. And do you have any chronic cough or chronic constipation?
No, no, sometimes only.
And may I know your occupation? What do you do?
Yeah, I'm not working. I'm retired, and I stay at home and do my gardening and all these my hobbies. That's it.
Okay. And any chronic condition like asthma or diabetes?
I'm having high blood pressure. I'm taking medicine for this. And yes, I'm having diabetes, but I'm controlling it with the diet. Previously, my doctor gave me some medication, but now because I lost my weight and it became better now, I'm just doing diabetic diet.
So you are in regular follow-up with your doctor, right?
Yes.
Okay, that's good to know. And can you please tell me about your pregnancies?
Yeah. So I have 5 deliveries, and all of them were vaginal deliveries.
Okay, any complications? Any
Um,
use of instruments during the delivery?
yes, the first time I had a forceps delivery, and then after that, always my labor is a little bit prolonged, and I used to have good sized babies. All my babies are chubby, and they are good size. And later on, I
Okay.
developed diabetes, so they are really like more than 4 kgs.
Okay. And were you up to date with your smears, Mrs. Rose?
I remember I did it last in when I was 65 years of age.
Okay.
And
And
they were
was
all
that
fine.
normal?
Yes.
Okay. And can I please ask you questions about your sexual life also?
Oh, yes.
Okay. So how is it affecting your sexual life? Do you leak while having sex?
Um,
Anything like that?
yeah, actually, my partner, he has difficulty. He's feeling that lump that you can, if you will check, you can see that lump coming out. It's really bothering me. So sometimes I have just pain at the tip of this. I don't know. I have seen one doctor before. He said there is some ulcer, and he gave me some cream, and I was relieved because of this. And they offered me actually excises and pessaries, but actually nothing is. And I don't like pessaries. I don't like it. So I used these things before, but it's not
Okay.
working anymore.
Okay. So, as you mentioned that you have some pain while having sex. So,
Uh,
have you ever felt that there has been some bleeding or anything after the sex?
no.
Okay. And you are postmenopausal since how long?
Um, I cannot even remember. I was at 50, 52 or 53 years. When I was 53, had
Okay.
menopause.
And did you get any symptoms like hot flushes and all for which you had to use hormonal replacement therapy?
I had a little bit, but I managed with my lifestyle
Okay.
modification. I never used any HRTs.
Okay. And are you allergic to anything?
No.
Any surgery on tummy or down below?
No.
Any family history of concern? Any cancers running in the family?
No, not exactly. Yes.
Okay. Do you smoke?
Yes, I am.
How many cigarettes in a day?
5 to 10.
Okay. Have you ever thought of quitting it?
Yeah, actually, my partner is a chain smoker. So when he smoke, I smoke with him also just to give him company. But yeah,
Yeah.
I think I need to reduce it.
Yeah, because it will help in their improvement of your condition as well. And also, if you undergo a surgery, it will help. If you will stop smoking, your wound will heal easily.
Oh, okay.
So I will give you the contact number of NHS Stop Smoking Services if you like, and then you can go ahead with that.
Okay.
Okay. So are you aware of your weight to height ratio?
Yeah, my BMI was like 28 before, but now I reduced my weight, so it is like 25.
Okay, that's very good. Mrs. Rose, so as to just summarize that you're having a sensation of having a lump down below since 5 years, and you have frequent urine infections, and
Yes.
you're also having bothersome sexual life.
Yes.
Is that a good summary? You want to add something?
Yes, and I'm wondering, actually, there is nothing in the history, but I'm thinking with my diabetes and my age and my high blood pressure, is there anything else? I mean, because I know there is no medication for it, and I have to go for surgery, so I need to know. I mean, am I fit? Is it possible at my age?
That's a good question, Mrs. Rose. Can I just examine you in presence of
Oh, yeah.
chaperone so as to have a look?
Yes.
Okay, I will just check from your tummy whether there is any lump or not, and my midwife will check your pulse and blood pressure at present. And
Yeah.
from down below, I will check if there is any discharge or any ulcer present on the lump, and what is the grade of the lump present there, and also the tone of your muscles down below. Will that be fine?
Yes. So you might be given a picture of grade 3 uterovaginal prolapse.
Okay. So after your history and examining Mrs. Rose, there are certain options for you which I will mention, and you're aware of your condition. Like this is a prolapse. Which,
Yes.
I will just draw and tell you. Like these are the muscles, our perineal muscles, which support the organs. With age and with the menopause and with the frequent childbirths, these muscles get weak, and the organs tend to sag down. So in your case, the womb, it tends to sag down because the tissues are weak now. So due to this, you are having this prolapse and the sensation of lump, and which is also giving rise to the frequent infections, and there is problem with the urine as well. And due to this, there is interference in your sexual life as well. Am I
Okay.
clear?
Oh, yes.
Okay.
So your
So
time,
coming to
10
the
minutes finished, but I want you to continue because you are going very well. Okay, continue.
So coming to the management plan, there are certain lifestyle modifications, Mrs. Rose. Like you mentioned that you did exercise, and also I just talked about the smoking cessation with you.
Yeah.
If you will like, then I will put you in contact with NHS Stop Smoking Services, and
Yes.
it will help you further. And regarding these exercises, have you undergone these exercises in presence of physiotherapist?
Yeah, this is long time before, doctor, when I started to have my prolapse. But recently, no. Yes, I had like physiotherapy sessions with the physiotherapist.
Okay, so I will recommend you to continue these exercises, to be in
Okay.
contact with the physiotherapist, because it will help you if you undergo the surgery as well.
Oh, okay.
Okay, yeah.
Because
So
I
now
thought
coming,
that now it is
yes.
all out and it will not affect.
No, it's not like that. Even if you undergo surgery and you maintain your muscle tone with these exercises, it will help you further in future, because anytime after the surgery also these symptoms can recur and the prolapse can rehappen.
Mm-hmm. Okay, I will do that.
Okay,
Okay,
yeah.
doctor.
So coming to the surgery, Mrs. Rose, one option for you is that, like, you're sexually active also.
Mm-hmm.
So for you, one option will be removing the womb and repairing any other sagging part if we find. We call it
Okay.
as vaginal hysterectomy with pelvic floor repair.
Okay.
Okay, so how do you think about this option?
Um, I don't know. It will take a long time, and at my age, I'm not sure that is this the only option?
No. There are certain other options as well. I'm just coming to it.
Yeah.
In case you want to preserve your your womb, in that case, what we can do is there's another surgery which we can do it from the tummy by the open technique or by the keyhole surgery.
Okay.
Okay, and under the pain specialist will talk to you regarding this. What anesthesia we can give you so that you are put to sleep, and then this procedure can be done, and your womb will be stitched to the backbone with a mesh. Am I clear?
Oh, so you are not going to remove it. You will just hang it
Yes.
with the bone at the
Yes,
back.
it will be hanged with the bone. Yes.
Okay.
Okay.
And it
The
can be
benefit will
done
be,
by a keyhole also.
yes, keyhole also. The benefit will be your symptoms will be reduced, your sexual life will get better, and but there are certain disadvantages as well as any other surgery. There can be bleeding, infection, or pain, and sometimes these symptoms can recur, and prolapse can also occur again.
Yeah. Doctor, so these are the two options I need to choose from them, right?
Yeah, there's one more option, but as you are sexually active, we will not recommend this option to you, which is called colpoclesis. In this,
Okay.
we close the vaginal passage. After
Yeah.
that, you're not able to have the sexual relationship.
Okay. So these are the three options. So which one is the best? What do you think?
It is up to you, Mrs. Rose, what you think. I will give you the written information regarding
Okay.
all these procedure and the leaflets. So
Mhm.
please go through it and you
Yeah.
can decide it. We can have one more appointment. I will refer you to my consultant as well.
Yes. Yes.
Then you can
Okay. Good.
have a discussion.
Yeah.
Okay, thank you,
So
Mrs.
thank you very much. Thanks a lot. Yeah, this is
Thank you for your
excellent.
time.
Okay. So this how you approach the station is very good, and this is a passing station for you, except for one point that you took like 15 minutes or 16 minutes.
Mm-hmm.
Mm.
Yeah,
Because you know
actually,
why?
this, yes, ma'am.
First of all, there is not much adrenaline like in exam. You are not under stress of that you need to finish in time. And the other point is that you took long time in history. So it all depends that if you are studying with your study partner or not. If you are practicing, I mean, with your study partner.
Yeah, but not much.
Not much, right? That's why.
Yeah,
So you have
but
to,
time is always a problem with me.
yeah, you really need to practice with your study partner in order to, you know, uh, like to finish history in time. And you know, it's not a very simple task. Even the people who are taking courses with me, until the end they are having like difficulty, and they are finishing in, okay, initially they are finishing their history in 7 minutes, 6 minutes, and the whole station is 10 minutes. So it's not possible, right? So you took like 7 minutes in history.
Yeah,
Yeah.
but I
So
could not understand what extra I have spoken in history.
no,
Why
nothing
I took
extra.
7 minutes.
Yeah,
Yeah.
there is nothing extra. Actually, there is nothing extra. But maybe the way that you speak can be a little bit, what you call it. So actually, before I do the model, how it should be, I want someone else to do the same station, and I want to show you that, like, I might go back to Dr. Bushra, because she has been practicing. I mean, so initially she was able to finish it in 6 or 7 minutes, and then she managed to finish in 4 minutes. But also, although I'm saying that try to finish your history in 3 minutes, but even if you are finishing in 4 minutes, then still it is okay. Dr. Bushra? Bushra, where are you? Bushra, can you unmute your mic, please? Dr. Bushra? Sabiha? Dr. Bhavna, I just want to end Dr. Lasita just now joined. She just started, so I don't think she can. So who else can show me how to take history in like 3 or 4 minutes? Bushra should be the best person, but she's not answering. Anyway, let's talk about it one by one. So let me show you one thing before I start to talk. I want to show you something. Yeah, this one. I want to share my screen here. And here you go. Can you see this screen, Dr. Selfie? Have you read it?
Yeah, earlier.
That's why you are able to explain, because some people cannot explain prolapse. So the organs within the pelvis are normally held in place by ligaments and muscles known as pelvic floor. And if these support structures are weakened by overstretching, the prolapse organs can bulge or prolapse from their position. When this happens, it's called prolapse. Sometimes a prolapse may be large enough to protrude outside the vagina. So you actually summarize it in one sentence and you said it very well. And you have to reassure her that prolapse is very common. So it's not something that she's the one who have it. And it can affect quality of life as it affected her quality of life, because she's feeling discomfort, heavy down. It affects her bladder and sexual activity. Although not bowel, but it affects her bladder, it affects her sexual activity. 3 things that you need to ask her, and you ask all of the 3 things. You ask about her bladder work, you ask about her bowel, and you ask about her sexual activity, and she told you by herself also. Prolapse can be reduced, and she already told you. If she will not tell you, you have to ask her about the smoking. As you said, stop smoking. Weight loss, she already did weight loss. Pelvic floor muscle training exercises, you asked to resume her exercises, which is good. And you said avoid constipation. And avoid heavy, I think you missed that point, avoid heavy lifting. Okay, treatment options.
Actually, I asked occupation due to that.
Yeah,
and
that's why. She's not having any kind of occupation that involves heavy lifting, actually.
Yes.
So you said about physiotherapy. Spaceries she already used and she didn't like it. So she's actually, she wanted to know more about the surgical options. And then you ask her about severity of her symptom, duration, any associated symptoms, which are all important. Duration, since how long, and the risk factors. I mean, you want to know why she has prolapse, right? So you just dig about the obstetric history. Actually, because surgery is her option, that's why you need to ask about her medical history, her previous surgical history, medications, what she's using, because she's diabetic, hypertensive, or any else medications, allergies. This all history quickly is important. And maybe smear postmenopausal symptoms. You ask about postmenopausal symptoms. Actually, you didn't leave any corner unturned. You ask about postmenopausal bleeding and hot flushes, which is very rare at that time, but you ask that she ever used HRT, because lack of estrogen or estrogen deficiency can be a risk factor for this kind of prolapses. Okay. And you ask about UTI, and she said, she actually, the patient, if she will not tell you, then you need to ask her. It's a good thing. What is written here? Half of women, like this point, this one, half of women over 50 will have some symptoms of prolapse, and by the age of 80, more than 1 in 10 will have had surgery for prolapse. If she asks you, then you will quote this percentage.
Okay.
That's why it is important to read patient information leaflet, because the percentage that is given in patient information leaflet is important to counsel a woman. If she asks you why it happened, then you can explain. And if she asks, because she didn't have like, only she has this one, uteroapical or uterovaginal prolapse, then she can have, you might like, although the time finished, but you might be talking about the recurrence also, like, or like not recurrence, but I'm talking about vault prolapse. I mean, the chances of vault prolapse that can happen. Because what is the percentage, what is written in the vault prolapse guideline? Do you remember? Recurrence.
No, I don't remember.
I think it's around 10%, if I'm not forgetting. That
Actually, it's given in the leaflet only. Scroll it down
It is
along
there?
with that. Yes, yes.
How is prolapse diagnosed? No.
Next
Test.
page.
Infection, you talk about infection. Did you talk about urodynamics?
No, I didn't talk about urodynamics.
Do I have to have treatment? Lifestyle changes, already you talked. Pelvic floor exercises. No, not important. Estrogen here, vaginal estrogen. What are my options for treatment? Like pessary, but if she never used pessary, then you should be talking about pessary exactly what is written here. You know, and it's a very good information about pessary, although it's given everywhere, here and there in the strategy and talk articles, but this is the one that how you should counsel a patient about pessary. Especially estrogen cream is sometimes used when changing the pessary. How frequently should you change it? Usually it will not cause problem, but it is possible to have sex with some of kind of pessaries. And then coming to the surgery, actually, because this patient is concentrating on surgery. Okay. Risk are, if you are overweight or have medical problem, then there's some risk, but you will be sent to the anesthetic. He will be the best person to choose the type of anesthesia for you. Either you will be put into sleep or you will be given a back injection. He will be the best person to choose. You can say that. So you need to be referred to the anesthetic before your operation. Now you talk about the vaginal hysterectomy and pelvic floor repair, and you talk about sacrospinous fixation. You didn't say because she's sexually active, right? That's why you don't want to talk about it. Yeah. And colpoclasis also, although if you don't want to talk about something, you can still talk about it, because because you are giving options. Maybe she was in a sexual relationship, and then now she will say it's maybe you can do it, because in future maybe she's thinking that something can happen and she might change her opinion about the kind of surgery that she want to do. She might decide to do colpoclasis. She's already, that's why you have to tell her about all the options, even sacrospinous fixation. Okay, how successful? Yeah, it's not 10%, it's 25 to 30 out of 100. You see, it's all information is given here that you need to inform. Now this patient, what information you need to give her is given in this patient information leaflet.
Right.
You need to choose only. Like here, it is detailed about pessary, but you will not talk about pessary too much, because she said that she tried it and she didn't like it. So you will come to surgery part. So you have to choose from these patient information leaflet. And the recurrence also, you have vault prolapse is 25 to 30 out of women will develop another prolapse in the future. And there's a higher chance of prolapse returning if you will increase your weight, because she is anyway, because of her age, she's not very mobile, right? She might get constipated, and because of smoking, she might develop chronic cough. And if you do heavy lifting and things like this, even at home, she can do it. And prolapse can happen not only in the wall, but at the point of your surgery, but it can happen with the at other parts also of the vagina, and may need repair later on. Okay, she might ask you this question, and if she might ask you this question, then you need to answer her like this. Okay, it's okay, Mishra. Now because this is about surgery, you need to give her some information, not only about the recurrence, but also about how much time you need to spend in the hospital. So it depends. It's few days, and you should avoid heavy lifting. This will be included in recovering well, but it is given here also that what precaution you need to do after surgery. Avoid heavy lifting and sexual intercourse for 6 to 8 weeks, because it is given here that that's why you need to counsel women about this also. And if you will say all these things, it will be like 20 minutes, right? Now Bushra is with me. But the good thing, which I like, that you ask about, you touched almost every. So this is a passing station, like quality of life, associated symptoms. You talk about the you ask all important points in history. Examination you touched, investigations, then safety points, all safety points you mentioned, which I like. And in your introduction was excellent, and you put an agenda. Then you ask her about her knowledge. You follow all the steps of how you are going to approach OSCE station. You follow all the steps. And then in
Thank you,
management,
Dr. Samira.
in management, you come to the surgery, you give her all the options, almost all the options, and then pros and cons of each surgical options. It is better that you have 2 minutes outside and write in your bullet points the pros and cons of each surgical option, because you might forget it inside. So these are the bullet points that you need to write outside. You need to write that this is a prolapse. These are the safety points, 3 safety points that I need to mention. This is the management options of surgical, and pros and cons of each management options. This is exactly what you need to write outside. Because like this, you will have 12 minutes instead of 10 minutes. Your time will increase if you will utilize this 2 minutes. Bushra? So thank you very much.
Thank you, Dr. Samira. Thank you so much.
Now Bushra is here. Unmute, Bushra.
Yes, I'm unmuted.
I want to stop my share and open the same scenario. I want you to just tell me how you will take the history in 4 minutes. Let me start my... Is this sound is coming from your background, Bushra? Because all of them are muted.
Maybe my sons are playing, I think. 1 minute.
Okay.
Yes, Dr. Samira.
Okay. Now let me start my... I'm starting my timer 4 minutes only. I'm giving you only 4 minutes. Okay, start your introduction now and your...
Hello, I'm Dr. Bushra, one of the doctor in the clinic today. Can I confirm your name and age, please?
Yes, I'm Mrs. Rose, and I'm 78 years old, doctor.
Okay, Mrs. Rose, what I know about your notes that you are here because you are suffering with something coming out from down below, and you are here to discuss the management option. Is this correct?
Yeah, that's exactly.
Okay, so please allow me to ask some questions from you. Then I will discuss your management, and I will also provide you with the information leaflet in writing so that you can have more knowledge about that. And
Okay.
maybe I will write back to your GP so that you can we can arrange further appointments for this management. Is that okay?
Yeah, that's perfect.
Okay, please will you please tell me more about the problem?
Yes. So doctor, since 5 years, actually since more than 5 years, start to have this, but since 2 or 3 years, I can see there is something that I can see outside the lump outside, and I feel it. It's very heavy, and it's uncomfortable. I have problem in my sexual life with my partner also, and I have
Okay.
problem in
I'm
my
sorry to hear that.
even I'm having like urine infection every now and then.
Okay. Are you feeling any problem in your urine? Do you rush? Do you need to rush to pass urine?
No, actually, I'm not able to pass urine. So whenever I want to pass urine, I have to, uh, I mean, physically like put this thing back
You have
inside
to
and
reduce
then
it back.
reduce it back.
Okay.
Yes.
There is there any vaginal discharge of foul smelling?
No,
Any bleeding? Have you felt any bleeding?
no, never.
Okay. As you said that you have problem with this urination, do you have problem also with your bowels?
Sometimes I have constipation, which I think all women have, all people can have, but not like too much.
Are you suffering any back pain or lower tummy pain?
No, just uncomfortable down below.
Okay. Can I ask about your? Have you ever been pregnant before, Mrs. Rose?
Yeah, I have 5 deliveries. All are vaginal deliveries.
Okay.
Yeah.
Okay. And what about the weight of the babies at the time of birth? Do you
Oh,
remember? Are
actually,
they okay weight or?
initially it was a forceps delivery, and then I had vaginal deliveries, but
Okay.
weights are always, they are big babies.
Okay. Do you have any problems after your deliveries in your postpartum period related to your urination, waterworks?
Yeah, I was not able to, whenever I cough and sneeze, I had like, I mean, I can feel that the urine drops comes out. But then I have been doing like exercises, it was under control.
Okay. Okay. Now, can you? You must. You don't have periods, right? Can I ask when the period stops?
Long time ago, doctor, when I was 52 years old.
Okay. Have you felt any hot flushes, sweating like that?
Initially, a little bit, but I didn't never use any HRT for this.
Were you updated with your spares before till the age of 64?
Yeah, 65, and it was all normal.
And it was normal?
Yeah,
Okay,
4 minutes
thank
finished.
you.
Now I'm checking how
Um,
many minutes do I need to.
Okay, as you said, Mrs. Ruth, just for me, a few more question about your sexual health. As you said, you have problem with this problem during your sexual activity. Can I ask you, do you have discharge or any other problem with this during your sexual activity? Are you able to do the sexual intercourse completely?
No, my partner is feeling problem in insertion, and we have difficulty. It's because of the lump.
Okay, few more questions, Mrs. Rose. That are you otherwise medically fit and well?
I have
Any
high
history
blood
of
sugar.
medical?
Yeah, and I have high blood
Okay.
pressure. I'm using medication for these. But now for diabetes, I stopped my medication and I'm doing diet now.
Okay, and you are following with your specialist, and these medicines
Definitely.
are controlling, right?
Yes, it is under control again.
Any operations for you before?
No, never.
In abdomen, tummy, lower down? Never.
No, no,
Is there any disease which runs in your family?
no, not
Okay.
specifically.
Can I ask, what do you do for a living?
I'm retired, so I am at home.
Are
So
you,
I'm having
can I
pension.
ask with whom you are living with?
Yeah, my partner,
Whom you are
and
living?
he's actually my husband, and I'm having retirement pension. Yes.
Okay, and he is you both together taking care of each other, or you
Yes,
have?
of course. No, some one lady is coming, like to help us at home.
Okay,
Yeah,
okay,
for a few hours.
okay. Do you smoke, Mrs. Rose?
Yeah, I smoke.
Can I ask how many cigarettes?
8 to 10,
Have you ever think of quitting it?
6 minutes. Yes, I thought about it many times, but I'm not able to because I'm just giving company to my partner.
Any alcohol?
No, occasionally on weekends.
Okay, okay, Mrs. Rose, thank you very much for sharing your information.
That's
Is
it.
there
That's
anything
it.
else you want to tell me?
Yeah, this is a good question to be asked at the end, just to make sure if you miss anything, she will direct you. So don't forget to ask her at the end of your history that if there is anything that you want to share with me, she will share with you whatever is in her agenda. So it's very, very important. Even if you miss something, you can ask her at the end. She will share with you whatever carries marks. She will share. So it's like history should take like 4 minutes maximum, but it took 6 minutes for you. And for Dr. Sulfate, it took like 7 minutes. So 6-7 minutes is usual for all of you. But you need to reduce it with practice. Now, what is extra? Extra things, if you will listen back to your recording, you will find out, Bushra, that you repeated yourself many times. And if you repeat yourself many, it was Dr. Sulfate, she didn't repeat herself many times.
Then
But
what I missed?
the problem is not miss. You actually, you didn't miss much. And you ask medical history, medication, allergy, surgery, family history, smear history, gynae history, occupation, everything you ask about associated symptoms, sexual, bowel, bladder. These are the things, and if it is affecting her quality of life and all these things, and what are the, I think you forget to ask about what has been done until now for this prolapse. Yeah. So which Dr. Sulfishi asked, that's why it became 7. So if you will ask this, then it will become 7 minutes for sure. So so it's okay. But for you, you repeat like few things. And
Yes, I was also noticing.
yeah, you were repeating.
And also fluent. I always say that fluency is less. Asking questions back to back should be there.
Yeah, so the same thing goes with Dr. Sulfi also, that the pace of her talking was a little bit slow. Yeah, so it should not be very fast. It should not be very fast, and it should not be very slow, and it should be clear, and the question should come back to back. But it looks from your history that you were thinking while you were asking. That's why you were repeating yourself. And
that's the reason of taking time also.
yeah, that's the reason of taking time. And the other reason which Dr. Sulfi also had, that you are talking about agenda. Now, talking about
Yeah, we
agenda is
have
fine.
to.
I mean, it's not
Yeah.
it's not carrying marks.
But some people said it is.
It's must. If you
Not
really,
much, because if we have talked about this, so like patient information and return to a GP or this, it will carry marks. So if we
now,
will not finishing the, so at the end we will not reach that. So it is
yeah,
taking
but you
marks.
can say that like in few seconds you can talk about that agenda. So now introduction, all of you are perfect. Both of you are good in introduction. You are not taking long time in introduction because more than this, it's not carrying marks. More than this, you don't have to introduce yourself more than this because it's not going to, it's going to waste your time. So introduction is perfect. Then coming to the asking part, that you want to know her background knowledge, which is a good practice. You have to ask her because maybe you didn't ask her about the background knowledge. That's why, no, you actually you ask.
No, I ask.
Yeah. You ask that what happened, since how long that she's suffering, and what other problems that she has. But then she said a sexual urinary, and since 5 years she has this and that. It's bothering her. What are the symptoms that are bothering her? It's heaviness and sexual activity. Oh, she said yes. Yeah, but you didn't ask about what treatment she has been. I mean, until now, what has been done for her. So this is the thing. Because if you miss that part, ask part after introduction, ask about her background knowledge and what has been done until now. Then you might go on talking about pessary for another 2 minutes, but she will tell you at the end of 2 minutes that, but doctor, I already used it and I don't like it. I didn't like it. So it's very important to ask what has been done until now. And then after introduction, ask, and after ask, coming to the agenda. Agenda can be squeezed to few seconds. How it can be? What an agenda you want to say? You will say that, is that okay, Mrs. Rose? I want to ask a few questions, and then in presence of a chevron, I might need to examine you. 1 second. And then we will talk about the options that you might have. And at the end, if you have any questions, you can ask. Like, it might take like few seconds.
Less than a minute.
Yeah, then you can talk about your agenda in less than a minute, for few seconds only, actually, because even 1 minute is very long time to talk about agenda only, that what you are going to do. And
Actually, if I see that this introduction, asking, and agenda, it takes almost 1 to 2 minutes.
yeah, this is what we need to reduce the time. So if you are introducing yourself in few seconds, you are asking in few seconds, it might finish 1 minute, right? So talking about agenda should take like 6-7 minutes seconds only. So because I don't want you to, all three things ideally should be within 1 minute. With practice, it will come. All three things should be within 1 minute. Okay, then you come to the history. In history, it's better not to repeat yourself. Once you say something, don't repeat it. The pace of your asking should not be very fast, should not be very slow. The other person should understand it, but it should be a little bit more than how you said, right? Little bit more faster, and without repeating yourself. Then you will be able to finish it in another 3 minutes, which will come with practice, of course. Whenever you are practicing with your study partner, you need to have a timer with you. So the same scenario, you do it, and then you ask the other person to do it, and then you do it again. and you are checking your time. So you practice taking history again and again with your study partner until you can take it in 4 minutes. Because if you take it in 4 minutes, then you have 6 minutes to talk about management. 6 minutes is more than enough. If you want to extend your history to 5 minutes, still, I mean, you can still pass the station. You can still finish in time. But more than 5 minutes, it's very less chance that you will be able to pass you will be able to finish that station. And even if you know you might not be able to pass because you are not able to finish. So never exceed more than 5 minutes. And don't forget about the safety points, which Dr. Silpian, you mentioned all the safety points. So this is what I want to say. Management is fine. There is no problem. Surgical options, pros and cons of each surgical option. Give her all options, even if she is sexually active. Explain a little bit about each option, exactly what is given in the patient information leaflet, and at the end talk about recurrence, recurrence of symptoms or walled prolapse or other pelvic other pelvic part prolapse like cystocele or rectocele can happen later on. So recurrence and what she expect after surgery. She'll spend few days in the hospital, and she should not do heavy lifting and sexual activity for another 6 to 8 weeks. This is exactly what is written. Okay. So any question before I move to the next station? And who like to do the next one? Dr. Lasita, are you able to do it now? Can you try?
Hello?
Yes, doctor. Can you try?
Not clear, doctor. Can you repeat the question?
I mean, can you try doing the next station? Do you want to try?
Next time, is it okay? Let me prepare a bit more.
The thing is, you know, why I'm asking you, because
Yeah.
I want you to talk. So even if you
Okay.
even if you are
Okay, I will try, doctor. Okay. That's
yeah,
fine.
because you know, you should be confident and you should
Yeah.
be outspoken. Just go and
Yeah.
start talking, even if you are talking is not making any sense. If no one is here to judge you, there is no pass
Okay.
and fail.
Okay.
Okay, let me give you this scenario.
Mm.
And okay, so it's a structured viva, right? And I'm giving you 1 minute, and all of you 1 minute. Please write your bullet points in your diary. How you are going to take this station inside the cubicle. Write these bullet points. I'm muting myself for 1 minute. I'm giving you 1 minute. Are you ready or you need more time for writing bullet points? Dr. Lasita, are you ready for your station?
Okay, doctor. Maybe wrong. I am trying for the first time.
That is
Okay.
why the structured viva is important. It depends upon your knowledge, basically, and your confidence.
Yeah.
Okay, and your broad way of thinking, that how you are taking a scenario, you know, broadly, and you are taking this patient individually, and not leaving anything like important things. And so that's why, and not neglecting the safety points. So don't neglect the safety points. I'm starting your 10 minutes and I'm going to ask you 5 questions, right?
Yeah.
Your time starts now. You have seen how people introduce themselves. Now go inside and introduce yourself to examiner.
I'm Dr. Lesada. I am one of the doctors in clinic. Your good name, please.
See, this is a structured viva, so you are addressing an examiner. How you will address an
Okay,
examiner?
okay. So,
I'm starting
good
again.
evening.
Okay.
Exactly, I don't know.
Bushra, how you will introduce yourself to an examiner, because we didn't practice with the examiner before with Dr. Lasita. Can you show us?
Yes. Hello, I'm Dr. Bushra, one of the candidate, and I'm ready for discussion.
That's it, full stop, not more than this, please. No need
Okay.
no need to
Okay.
I mean, say I am one of the senior doctor, and I am Dr. Falana Falana, and I am good morning, good evening, nothing at all, because it doesn't carry any mark.
I'm Dr. Lesada. I'm one of the candidate and I'm ready for discussion.
Perfect. Okay, doctor, you have read the scenario. Can you please tell me that what information you need from this patient?
I want to know about her symptoms, details of her symptom. What about the duration of the symptom? Severity of her symptom. Whether it's interfering with her daily activities, her quality of life, and whether there is associated fecal incontinence.
Yes.
And I want to know about her details of her delivery, pregnancy also, any antenatal complication like gestational diabetes, increased LICA, and multiple pregnancy, like that, and details of her delivery, birth weight of baby, duration of labor.
Yeah. So you want to know the last delivery?
Yeah, last delivery 6 weeks back.
Yeah. So you want to know the details of this?
Yeah,
delivery. And her obstetric history, you mean?
Yeah, her obstetric history, about the healing of episiotomy, whether there was any episiotomy infection.
Okay.
Whether she has done pelvic floor, know about pelvic floor exercises, whether she has done that.
Yes.
Yeah.
Okay. So that's it, you will ask her. Okay, what about, so this is the information you need from this patient, right? So
Okay,
what investigation?
I know it's very incomplete. I will improve later.
No problem at all. No, this is perfect. So what investigations you need to do? By this time, you should have differential diagnosis in your mind. So, doctor, can you tell me about the investigations that you need to do?
First, we have to do a clinical examination.
Oh, perfect.
To know about any cystocele, any descent of uterus.
Okay.
Any perineal tear.
You mean healing of episiotomy, for example, if she has. Okay.
Yeah. A tone of her pelvic floor muscles.
Okay.
And obviously any fistulas or
Yes.
obstetric fistulas.
Okay. So this is what you need to examine. And what about her BMI general examination?
Yeah,
Also.
of course, BMI, general health,
Yeah.
and anemia can precipitate obesity.
Yeah.
So,
Okay.
general health. And blood investigation. I want to do a complete blood count to know whether there is anemia, whether there is any infections, urine routine examination.
Yes.
Blood sugar values.
Okay.
Hello.
Yes. And okay, so what is the differential diagnosis?
It can be a stress urinary incontinence following pelvic floor injury, or it can be a fistula. These are the two.
What else?
Differential diagnosis.
The common things are common?
Common things.
Like, can she have urine UTI?
Infections.
Infections, yes. Okay, so now coming out of this patient, if for example the same patient present to you in few days and she will tell you about the signs and symptoms of voiding dysfunction, so how you are going to manage her? For example, she comes to accident and emergency department, she said, I'm not able to pass urine on third or fourth day. So how
we have
you will manage her?
First, we have to examine whether her bladder is distended,
Yes,
whether
perfect.
uterus is contracted, any pelvic hematomas are there, and see her general condition. And we have to immediately relieve her symptom by catheterizing the bladder.
Okay. Now, what you will check while you are catheterizing her?
The color of urine, the amount of urine.
Yes. So, what's the importance of amount?
Hello?
Yes.
Amount. We want to know whether it's an overflow incontinence or a stress incontinence.
For example, the same patient, you drain 600 ml. Now, what's next? Are you going to admit her? The first thing in management comes with decision of admission or not admission, right? So you will admit her, right? So after admission, what you will do? Are you going to leave the catheter? Dr. Lasita, are you going to leave the catheter? What happened? Dr. Lasita, are you going to leave the catheter? Yeah, Lasita.
Yeah, doctor. We will see whether she passes urine. We want to know the cause for urinary retention.
Okay.
Whether she has got any infection.
Yes.
We will check urine routine and see whether she passes urine again.
So you are going to admit her, right? So after admission, what you will do? Are you going to leave that catheter inside, or it's just an indwelling catheter?
I think more than 1 liter we will keep the catheter, I think. Yeah.
Okay, no problem.
Otherwise,
So if she has 600 ml, you will just do in and out. This is what you are saying?
and we'll see whether she's passing again.
Okay. So you will admit her, you will observe her, and if you see if she's not passing again, not able to pass again, then you might leave the catheter. For how many hours you will leave?
I'm not sure, doctor.
Are you going to refer her to someone?
Urologist now.
Okay. If you have urogynecologist, you can refer to her. First of all, you will talk to your consultant. So what is the, for example, if you leave the catheter for uh, 24 hours and still she's, what is the amount of residual urine that is acceptable that you can remove the catheter after 24 hours? Do you know the cutoff?
Residual urine. 100 ml, less than 100 ml.
So you mean if it is less than 100 ml, you will remove the catheter, right? But if it is more than 100 ml, then you will leave the catheter. So for how many days you will leave?
2 weeks.
Yeah, for example, you leave it for 1 week and you ask her to follow up in the clinic. And then you will might admit her for a few hours and take care, and you will see, you will observe if she's able to pass urine or not, and how much is the residual urine. So if it is more than uh, 100 ml, then what's next?
We have to refer to a urogynecologist.
Yes, perfect. And what else? Can you what urogynecologist do you think he will do?
I'm not sure, doctor.
Okay. So so you are going to do intermittent catheterization. You will ask her, you will teach her for intermittent catheterization. So the time is up, and I ask 4 questions. One question is remaining.
Okay.
Because I wanted to ask you, even after the time finished, that for example, she has voiding dysfunction, and of course you need to do urodynamics for her and pressure flow studies, right? For,
Urodynamic study, yeah.
the urinary flow study, this bell shaped diagram will be there, filling and voiding cystogram, cystourethrogram even, and voiding dysfunction studies, which is pressure flow studies. All needs to be done before you will decide what you need to do.
Okay.
So now I want, because initially I talked about the importance of theory. So do you know how important is it
Yeah.
that
It's the base.
your theory should be very good? You will not be able to pass the station if your theory is not good. Now, once you will look at the scenario, for example, this scenario, you should immediately know what is my reference. Here I showed patient information leaflet, and you have all your information. Information about prolapse is in a talk article, is in strategy, and a little bit in the World Prolapse Guideline. There is no guideline of prolapse, but there is a talk article and there is a strategy also. In strategy, a detailed discussion about prolapse. But your reference should be patient information leaflet, because you are going for counseling a patient, right?
Yeah.
With your background knowledge of a guideline and a strategy. Okay, now for this, what should be the reference of your knowledge? Once you look at the scenario, you should immediately know what is my reference. So what do you think
But mm,
should be the reference of this? Is there any guideline?
no, postpartum only. No, urinary incontinence. There is no green top guideline.
Okay. What about the TOG article? Do we have TOG articles?
Mm,
Here, there is no need to refer to the patient information leaflet because you are not talking to the patient.
patient to the examiner.
So you should rely on your guidelines
Mm,
and TOG articles and strategy. These are the
mm,
sources that we have, right? The reliable
yeah,
sources.
yeah, yeah.
जी जी
Which
बेटा
is the source for this, doctor?
Do you have any TOG article?
चलो कोई बात नहीं कोई बात नहीं कोई बात नहीं
Do you have any TOG article?
I have talk articles. I have, but
Related?
this one I don't remember.
Yeah, so then let me show you.
Mm,
What are the TOG articles related to it? And I will show
yeah.
you something very nice.
Mm,
Uh, because there is one TOG article. Let me show you. Yes, management of urogynecological. Let me share it.
mm.
Share the screen. Yeah, this one. Can you see this one?
Yeah, I can see. I can see.
Yeah. So it is 2012. It's a little bit
Yeah,
old.
yeah, yeah.
The management of urological problems in pregnancy and early postpartum period. So
Okay,
here they
okay.
talk about UTI. If you look at it
Mm,
like just a glimpse of it,
mm,
they talk about UTI. They talk about stress incontinence.
mm.
Talk about
Overactive blood.
surgeries related to stress incontinence and then overactive bladder. They
Mm,
talk about prolapse.
mm,
This is part of your differential diagnosis, what is written over here.
mm,
So in summary, they are saying the lower urinary tract symptoms are common. So effective diagnosis and treatment of UTI. So the first thing they are considering, so what I said, common things are common. In your differential
UTI.
diagnosis, you should talk about UTI first.
UTI
And
first.
it is
Okay.
written exactly in the TOG article. If you remember this TOG article, you will immediately answer me, right?
Yeah.
Now, urinary incontinence is common during pregnancy. You should ask her that
Yeah.
because if you know your differential diagnosis, you will ask history, targeted history only
Okay,
from
okay.
this patient because the examiner asks you what information you need from this patient. So you
Yeah.
should have like differential diagnosis because then his next question was what is your differential diagnosis? But it should be from the beginning, actually, in your mind, because you want to ask the targeted information or targeted history from the patient on the basis of your differential diagnosis. So common things are common. UTI.
Yeah.
After that,
UTI.
you need to ask her because you are predicting maybe she has stress incontinence because it is not written what kind of incontinence.
Yeah.
So first of all, you need to ask history, whether it is stress incontinence, it is fun
Or
symptoms due to detrusor overactivity, or she's having symptoms of prolapse, or she's having symptoms of fistula. The fistula
yeah.
should come at the end. The first thing is common, which is UTI, is stress
UTI.
incontinence, which is the second common. In pregnancy, it can happen, and after delivery. Okay. Okay. The effect of pregnancy on previous POP surgery is not known. Women presenting with symptomatic pelvic organ prolapse. So they talk about prolapse now. So UTI, stress incontinence, detrusor overactivity, because they just said urinary incontinence. It includes both or mixed. And then they come to the organ prolapse, isn't it? And then
Yeah.
here, although they have not written it, but just incontinence can be a sign of fistula even. So it should be in your list also. And you should be asking about voiding dysfunction, although it is unusual at 6 weeks to have voiding dysfunction. Usually voiding dysfunction patient, that's why I changed the scenario in my last question.
Immediate third day.
And I said that no, she comes 3rd or 4th day because I wanted to know your knowledge of voiding dysfunction. After I know that you can think broadly when a patient comes to you, how many differential diagnosis is in your mind? Then I want to know about voiding dysfunction. So let me show you that when I ask you about avoiding dysfunction, what TOG article should come in your mind? Do you know?
Yeah, 2012 dog article.
Very old one.
Yeah.
Let me share it with you. Because there is no other article after that about voiding dysfunction. That's why you have to rely on even 2008 article. Although it's very old. Just look at the date.
2008.
And it says postpartum voiding dysfunction. Everything you need to know about postpartum voiding dysfunction is over here. So you are asking about the history. Did you ask about epidural?
No, doctor.
Yeah,
It
because
was a very incomplete history, and I will improve.
yeah. History was incomplete, but there is no problem at all because I wanted you to talk. Because in this exam, if you are shy, then the chances are then don't go for this time, the next exam. So you need to have confidence, and how your confidence will build up. Whenever anyone asks you to start talking, you should start immediately. Whatever, if it makes sense or if it's not makes sense. This is the key of passing part 3, that you should be very talkative. This is not the place to be shy. So gravida, how many gravida she is, and if it was instrumental delivery, epidural, prolonged labor, tears. Anyway, now come to this one. Now, let's see. Here they are saying that postpartum warning signs. Overt urinary retention is the inability to void postpartum. So she had urinary retention. There are 2 kinds. Covert retention, when a woman has a residual volume more than 150 ml. So our cutoff is 150 ml. With no symptoms of urinary retention. So she will not feel it, but still she can have retention. It's called covert retention. The effect of covert voiding dysfunction, because maybe she will not have the symptoms. Why I'm saying this, that maybe this patient will not show you the symptoms of, will not have the symptoms of urinary retention, but still she might have it. So you need to check with the bladder scan her residual volume. So if it is more than 150 ml, then it means she has covert retention. Now, let's see, voiding dysfunction in the postpartum period has not established an increased risk of future urinary problems. Now, a residual volume more than 150 ml can happen in around 1.5% 3rd day. So the importance of this is, that's why I changed the scenario to 3rd day, because I know that it happens in 3rd day or 4th day. She will come, she will not wait for 6 weeks, you know, if she has symptoms. Okay. Add a 4-year follow-up by questionnaire. Prevention, therefore, okay. Let's see. This flow chart is very, very important. If you only remember this flow chart, this is an excellent flow chart. I really loving it. So you see, this is
more than 500 ml. Okay, doctor.
Yeah, this is what I want. If you don't remember anything, just remember this.
Yes.
So if it is more than 500 ml, you have to insert the indwelling catheter for 24 hours. And if reassess if a residual volume is more than, so your second cutoff is 150. If it is more than 150, then leave the catheter for 1 week.
1 week.
Yeah. And then reassess. If persistent voiding problem, then teach intermittent catheterization and refer for urogynecology.
Yes.
All the answer of voiding dysfunction, of management of voiding dysfunction is over.
Yeah.
And how, here, look at this statement. After epidural, why the importance of asking about epidural, that bladder emptying should be documented in all women during labor. There is no guideline or how frequently, but every 4 to 6 hours should be. And after epidural, do you know that what is the importance of asking about epidural?
Urinary retention is common after epidural, inserting an epidural.
For example, a patient has epidural, you remove epidural after that, after delivery. After how many hours she should be able to pass urine? You need to check if she's able to pass urine. So what is your cutoff?
Within 6 hours.
Yes, your cutoff is 6 hours. You are right. The catheter can be placed up to 2 weeks, which you are fine in. So after 6 hours, patient should be able to pass urine. If she's not able to pass urine after 6 hours, then you have to check her residual volume. Maybe she's dehydrated and she has no urine in her bladder, isn't it?
Yeah. Oh, yeah, true.
So you need to catheterize her for sure if it is more than 150.
Yes.
Okay. Does it mean that this is the normal residual volume that a woman should have?
No.
What is the normal?
This is after delivery, less than 50 ml?
Yes. So it is less than 50 ml, but this is, they are talking about
After postpartum.
yes, they are talking about, so you don't mix two things. Okay. So after 6 hours, patient should be able to pass urine. For example, if the same patient received top up at the time of delivery, then you should leave the catheter for 12 hours. And it is written in one of the talk article.
Okay.
And for your practice also, if how many times patient on epidural, we ask the anesthesia, she's going to deliver in in 1 or 2 hours, but she cannot tolerate the pain, she need top up. It happened to me many times, and the anesthesia is coming and giving top up.
Yeah.
Now you have to leave the catheter for 12
For 12
hours.
hours.
Yes, after the top up. Few people knows this.
Yeah.
So this might be the cause of this retention. And she can develop, like, it is temporarily, it's not going to affect her urological for forever, but it can be the cause of this urinary
Cause for immediate retention.
and UTIs. Okay. And so in history they were, of course, let me stop my screen, come back. Okay, let me see who is there to see how you will take history. So you managed to finish on time. This is something I should appreciate something. How come? And the most important thing that I want to appreciate, that you talk. You are not shy anymore. I'm happy. So no, I don't want people to see that they are shy, they cannot talk. No problem at all. If your English is good or not good, doesn't matter at all. Some people are shy because their pronunciation of English or their vocabulary is not enough. It doesn't matter at all. This is not an English language exam. I have seen people with very poor English, they pass exam. And they are not expecting overseas to have perfect pronunciation, accent, or a lot of vocabulary. They are not expecting from us. But they are expecting from us knowledge and the skill of approaching to a station, right? So, and the confidence. How everything will come, everything will come. For you need to read your knowledge.
Yeah.
I can direct you what to read. You see, this is the maximum what I can do. I can direct you what to read, but I cannot read in your place. You have to read by yourself.
Yeah.
The other thing, how to apply it, this one, it will come with practice. You have to leave. This one will come with practice. Skills will come with practice. What to read,
Okay.
I can guide you, but you have to put your effort and read it.
Yeah.
So it was good. You've managed to finish in time. You have the courage to attempt, although you were not ready. This is excellent. Okay. And your knowledge was not that bad. It's only that you didn't revise.
Yeah. The topic I was not well versed.
Yes.
And first time I am joining a group for part 3. So I will
Oh,
try that.
wow.
Next time I will.
So because there are many groups and there are a lot of discussions going on, free mentors are
Yeah.
doing free discussions. So
Yeah.
that's why I'm surprised. So, but no problem at all. Even if you are starting, and this is your level, then this is good. I'm happy. So, Dr. Bushra, I want to ask Bushra that how to, if there is anyone else want to contribute, how to take history, because there was some deficiency in history, in information, when the examiner asks what information you need from this patient. So this is the answer that I want from someone else. Dr. Mehvish, have you joined or not? Are you there? Anyone who want to contribute?
Yes, Dr. Samira, how are you?
Yeah, good. Who is that?
Salma.
Okay, Dr. Salma, do you like to tell me how you will answer this question? What information you need from this patient?
Yeah, first of all, I have to ask her that now that she has this urinary incontinence, so her present symptoms about urinary incontinence, that she need to rush to go to toilet how many times, and she leak with her any laughing or sneezing, she leak
Before
urine.
you answer this,
And
I am just interrupting you. Sorry, I have to interrupt you. What differential diagnosis you have in your mind?
yeah,
Because
differential
you will
diagnosis
ask
first.
question according to what you have in your mind, right? Differential diagnosis.
Yeah, first, first it will be the urine infection,
Yeah.
urinary tract infection.
Mm-hmm.
Then it will be the stress urinary incontinence and
Okay.
urinary incontinence also.
Mm-hmm.
That
You mean
and
Detrusor
but
overactivity symptoms or overactive bladder
yeah, that
symptoms? Mm.
yeah, that
Okay.
is over symptoms, and then avoiding dysfunction. But it is 6 weeks, but it is unusual.
Yeah.
Okay,
Still,
and
you can ask
so
about
relate.
the retention, symptoms of retention. You can ask because she might have some symptoms of retention. Even if she has UTI, she can have
Yeah. So retention, I'll ask that she feel any distension on her
What are
tummy.
the what
Inside.
are the history in history you should ask about symptoms of retention or avoiding
Yeah, that
dysfunction.
she can pass urine. That is there any difficulty to pass urine, and how long she is this having this
Flow.
incontinence problem?
What
Okay.
how is her flow? Is reduced flow, and or if she is able to pass urine very fast, or if it's
Yeah.
very slow passing urine
Yeah.
flow.
Any difficulty? Yeah. Any difficulty?
Dribbling.
Yeah. Yeah.
So
Dribbling
because you are
and also.
talking to the examiners, then you can use these words. There's no problem. So you can say that I'll ask
And
about the flow, I'll
she can.
ask about the dribbling at the end, and feeling of still passing the urine at the end So these
And
are the
she can completely pass urine or not.
yeah, hematuria
Okay.
also, because it can be a red flag.
Yeah. Any burning sensation? Any burning
Yeah, you
sensation?
can say UTI silent symptoms
Mm-hmm.
like dysuria and burning maturation, because you are
Yeah.
talking to examiner, it's fine.
Yeah. Yeah.
So what is at the end? You two things. that
And also, I have to ask about the history that she she will she's after delivery that she has immediately these symptoms, or that, or
no,
before she has this
what's
problem.
in your differential diagnosis list is still two things remaining.
Yeah,
Because
then
your
it's just
history cannot be complete if you will forget about these two things.
yeah, especially in she has any leaking of this, any leakage, urine leakage,
No.
especially
Yeah, you mean what is in your mind? Why you are
especially
asking? Okay, there are two things that is part of
and
the differential diagnosis. You are forgetting.
voiding dysfunction and Detrusor overactivity also.
Yeah, but there are still two things. Bushra?
Urinary infection, prolapse.
Infection, I told already.
Yeah, she said infection. Two things, Lisita, which you mentioned.
And a pelvic organ prolapse also.
Yeah, prolapse
Prolapse. Yeah.
and one more thing at the end of your list.
And
Not very complete.
Fistula.
Fistula.
fist-
Yeah,
yeah, fistula.
if you don't
But
have this differential diagnosis in your mind, you cannot be able to completely tell what history to the examiner. That's why it's
Any neurological problem she can have because she's not feeling to pass the overflow due to?
I will tell you something.
Oh.
There are two kinds of detrusor overactivity, right? And one is the idiopathic and the other one is neurological.
Yeah.
Yeah. So yes, it is possible that if she is having neurological detrusor overactivity, then she will have overflow incontinence. So she will have incontinence, but overflow incontinence. And
Yeah,
how you will know? You will know by doing the urodynamics. Yeah.
And
you are right, but it will come in the history of detrusor overactivity, because there are two kinds of detrusor activity. One is overactive bladder symptoms, fun symptoms, together with the retention symptoms. So if you will ask these symptoms, then neurogenic will be and it can happen, especially if she took epidural, then maybe she has some neurogenic problem and she's not feeling the distended bladder and it just having overflow incontinence. So it can happen. That's why neurogenic can happen.
Yeah.
That's why I'm saying that asking about voiding dysfunction history is important, especially related to the epidural, because you will go back and ask about the history of epidural. If it is not in your mind, then neurological not in your mind, then you will not ask the history of epidural. That's why making differential diagnosis in your mind is very important.
No, we have to ask her delivery history also, how she delivered, and obstetric history, and she took the epidural or not, and
there is no age here, so you will ask about her age. Of course, after asking this, there is a pattern, right? There's a format: history of presenting complaint, why she comes here, what treatment she has taken until now. She's 6 weeks. And what is the severity of her problem, what kind of symptoms, with these symptoms, what are the associated symptoms, and if it is affecting her quality of life or not. So going back to obstetric history, then medical histories, allergies, medication history, surgical history, these are important. So
BMI also.
And her normal symptoms. She delivered. Don't forget, guys, she just delivered. This is her first postnatal visit. And it carries marks. Asking about her baby, how the baby is doing, breastfeeding, asking about contraception, asking about lochia, her cut, episiotomy wound. Is there any problem? Is as important.
And also she can have before also this urinary incontinence before
yes,
pregnancy.
asking about during pregnancy.
past
if she
history
was
has.
suffering from stress incontinence before. Maybe she
Before.
already have overactive bladder symptoms. Maybe she already has stress incontinence symptoms, and it just get worsened.
Yeah.
So all will come. All history will come to your mind. First, write bullet points of differential diagnosis outside. You have 2 minutes. Please use these 2 minutes effectively.
And her PBS, she has any baby, and PBS delivery history also. Maybe she has PBS delivery also problem.
Obstetric history. All will come. Just write the bullet points of differential diagnosis. And everything you will ask inside. I want you to write these differential diagnosis bullet points outside, and write some or more bullet points like what you need to cover. Like in age is not given here. You need to ask about her age. What are the important things? What are the safety points? You need to multidisciplinary approach. You need to ask her about the medication and the allergies. You need to refer her to the consultant. The red flag symptoms, you need to ask her like if she's having any hematuria, if she's having pressure, abdominal pain, distension, or what you call it. Maybe there's something which is causing pressure on her bladder, you know. So ask about the abdominal distension, and asking about infection is a safety point also. In medication, asking about allergy is important, referring to the consultant, urogynecologist at the end. I think these are the safety points here. Is there any safety point, Bushra, which I am forgetting?
BMI, to ask about the BMI.
Yeah. What information you need from the patient? Asking about BMI, yes, is also important.
And she has enough support at home because after delivery.
I'm glad that you didn't go on and ask about how many glasses of water and tea and coffee she's taking, but maybe asking about, because you know, you don't know what exactly she is having. If if it's a clear-cut stress incontinence, then you can say, I'll ask about the history of how many glasses and this and the constipation. But you know, as part of social history, because your history might not be completed if you will not ask about smoking alcohol. Smoking alcohol and drugs. So it's okay. You can ask about the quality of life also, if this is affecting her quality, because this is how your history will be completed. What information you need from this patient. Anything, Bushra, you want to add?
No.
Anything else?
Discussed in detail.
Yeah. Okay. So I was planning to do this session for 2 hours. Now it's more than 2 hours. Just, you know, here I'm not doing like, I can do like 10 minutes discussion and 5 minutes, what you call it, the model answer, feedback, 5 minutes, 10 minutes station, 5 minutes feedback. This is usually what, but we should do it before exam in order to practice. We should do it, but not now. You need to understand. I mean, now it's more important. You have a lot of time, and you need to understand how you should approach, what you should read, and how you should approach a station. Isn't it? It's important to understand how you should approach the station before you actually, so you can do together, both of them together. You can have a study partner, start practicing with the study partner, bring 2 or 3 books like the Kunji book, the new one, start practicing it with your study partner. So in this way, you are speeding up. And with me, you can understand, like with other mentors also, that how to approach a station, and I will show you what to read also, so that you can direct your theory to part 3. This is different from part 2 reading. Okay, for some things you need to read patient information leaflet, but not everything is there in patient information leaflet. So you need to refer to for structured discussion, you need to have your knowledge of TOG and guidelines. And for simulated patient, you need to read the patient information leaflet. I mean, so it's just a few tips but sometimes there are some TOG articles which are very old, and you don't even remember that they are there. So it's there should be someone to remind you that no, we have a TOG article. Immediately when you look at the station, you should know immediately that from where this knowledge comes from. Then it will become very easy for you even to do the structured discussion if you remember the source. I'm going to stop recording.